Okay, so I have to. So then I can. How can I see the answers of the students?
Dr. Bimal sir can help you. Actually, if someone want to see the chat box together with the PPT, one presenter must join with the application. But you have joined through the browser, sir.
So okay, I will be explaining. So
Uh,
I will not. So this will
yes,
not be
sir.
an interactive class.
Sorry, sir.
So I cannot see the answer of the students, na? Last
Sir,
time I was
you
able
can
to
only
see.
see after stop sharing.
Okay, so every time I have to stop share, see the answer, and then come back.
Sir, that's the only, sir, it's possible in the browser.
In the WebEx app,
Yeah, in Webex app, both of you can see at a time, chat
so
box and
if you give me
PPT
2 minutes,
both.
then I can join with the WebEx app.
Okay, sir.
Okay,
Sir, then you have to leave the session.
okay. Just wait for a minute.
ये क्या है यार? अंकित वैसे ही शुरू कर दो यार।
यस सर।
उसको नहीं
यस सर।
Dr. Ankit, start in whichever way is possible. In
ठीक है.
any case, I am not expecting too many good answers. So it is okay. I mean, please start.
सर अभी
Okay, sir.
स्लाइड शो
Yeah,
अभी
yeah,
सर आ,
yeah.
सर जस्ट मिनट, स्टॉप के नेक्स्ट में एक डायगोनली एरो साइन है, उस पे सर आप क्लिक कीजिए तो कुछ ऑप्शंस अपीयर होंगे।
ठीक है. More sharing options.
हाँ तो चैट, एक चैट भी उसी में अपीयर होगा सर।
इसमें तो कहीं नहीं हो रहा.
सर
चलो ठीक है.
मोर होगा या चैट हो, मोर में क्लिक करने के बाद चैट आएगा या फिर डायरेक्ट चैट आता है?
नहीं आ रहा इसमें कुछ.
चैट आता ही है सर।
So, Dr. Ankit, let's start.
Yes,
I
I'm
mean,
starting, sir.
because,
ओके सर।
yeah, please, regardless of chat, wherever required, I'll intervene. Otherwise,
ठीक है.
you can continue.
So to begin with, first we have to identify the what are the various pressure tracings. So how can we identify these pressure tracings is, first we have to identify what is the part of the systole and what is the part of the diastole. So in a hemodynamic trace, usually the ECG is given. So from the peak of the R wave till the end of the T wave is the uh, systole, and after the T wave till the R wave again is the diastole. So few points which are the golden points which you have to remember before identifying any slide is, both the ventricular and the atrial pressures are upsloping in the diastole, but the arterial pressures are downsloping in the diastole. It means the blue one is the ventricular pressure trace, the gray one is the atrial pressure trace. Both are upsloping, increasing in the diastole. However, the arterial pressure trace is going down in the diastole. What is happening in the systole? Systole means the arterial and the LV pressure tracing are peaking up. But where the atrial pressure traces are peaking up, one is here in the diastole and one the V wave again in the diastole. So the atrial pressure peaks outside the systole, that is outside the STT segment. However, the arterial and the LV pressure peaks during the STT segment. That you have to remember. Second thing, in the diastole, the arterial is going down and the atrial and the ventriculars are going up. So just to summarize, what is the cause of A wave is because of the atrial systole. C wave is because of the closure of the tricuspid valve or the AV valve. The X descent is because of the relaxation of the right atrium and the downward pull of the tricuspid annulus. The V wave is because of the venous filling where the tricuspid valve is closed, and The Y descent is because of the tricuspid valve opening. So how you can identify? The V wave will always peak after the T wave. The A wave will peak after the P wave. That you have to identify. So again, this is the atrial pressure tracing. How will you identify a A wave? The P wave is occurring just after the P wave. Just after the P wave, there will be the atrial wave, which is called as A wave. After the T wave, whichever the positive wave is occurring will be the V wave. And the descent will follow the A and the V wave.
Yes, sir.
So coming to the first spotter, you have to identify the trace.
Control something.
So can anybody identify this trace? So these are two traces, the trace A and trace B. Which one is AS and which one is HCM?
No, students, you have to give explanation also. I mean, many of you are getting too impatient, but those who are getting too impatient are not answering. So kindly answer. Give the findings. Dr. Ankit, you are not able to see the chat, right?
So I am able to see some of the chats.
Okay, you are able to see. Okay, great. Then that's so nice. So nice. I thought you are not. Then that's okay. Then I don't need to intervene.
Okay, so the trace A, as somebody said, it is a late peaking. So this is a slow rising pulsus parvus et tardus. First of all, you have to see in both the things, there is a clear-cut gradient between the ventricular chamber and the arterial trace. So we are assuming this is the LV and aorta. So there is a clear-cut gradient between the LV and the aorta. So something is there is a LV outflow tract obstruction. So you have to start like that. This is a case of a LV outflow tract obstruction with a resting gradient between the aorta and the LV. This gradient can be because of the hypertrophic obstructive cardiomyopathy or can be because of the valvular aortic stenosis. So slow rising, late peaking pulse is suggestive of valvular aortic stenosis. And here this is the spike and a dome pattern, which is a suggestive of hypertrophic obstructive cardiomyopathy. And here what you can see is what extra thing is shown in the figure B. Can anybody tell what extra is shown in figure B in a patient of HCM? Very good. Somebody told it is a large V wave. So there can be associated mitral regurgitation also leading to the large V wave. So how you can identify this is a T wave, a wave which is peaking after the T wave will be a V wave. So this is the V wave. You can see a large V wave here, which is suggestive of the associated mitral regurgitation. Or it can be because of the stiff left atrium also because of the severe concentric left ventricular hypertrophy. This can be also because of the stiff left atrium. Need not to be have a MR. Can be also in the because of the stiff LA, you can have a large V wave. Okay, identify this trace. I have already given the hint. So very simple trace, no answers. Sarthak Gureja, broken bro phenomena. So that is the problem. So you are just answering without understanding anything. Okay. So somebody gave some answer. So to begin with, how will you explain this trace in exam? So this is a case, again a case of where LV and aortic pressures are being shown simultaneously. There is a clear-cut resting gradient between the aortic pressure and the LV pressure. So this is again a case of LV outflow tract obstruction. Then a premature ventricular beat came. What happened after premature ventricular beat is your concern. So what happened is, this was the aortic diastolic pressure. Aortic diastolic pressure decreased. There was a decrease in the aortic diastolic pressure, and this has led to the increase in the pulse pressure. There is no change in the gradient between the aortic pressure and the LV pressure. There is a slight potentiation of the LV pressure, but there is practically no change in the gradient. But the pulse pressure increased. So this is a case of fixed LV outflow tract obstruction seen in the valvular aortic stenosis. So why does this happen? Why does this pulse pressure increases? Can anybody tell? Why this pulse pressure is increasing? So what is happening is this ectopic beat is coming early. This ectopic beat has a low cardiac output during this ectopic beat. So for the hemodynamic compensation will take place, an acute fall in SVR occurs. Acute fall in systemic vascular resistance occurs. This leads to the decrease in the aortic diastolic pressure. And during this compensatory pause, because of the Frank-Starling law, the LV contractility increases. Here, the pulse pressure is already decreased. And because of this increased LV contractility, there is a more slightly increased systolic pressure of the aorta. So the gradient practically remains the same. The pulse pressure increases. The increase in pulse pressure is because of this ectopic beat, because this ectopic beat has led to decreased cardiac output because of the poor LV ejection here. You can see the poor LV ejection. The poor LV ejection has led to the hemodynamic regulation, leading to the decreased SVR, decreased diastolic pressure, increased pulse pressure, and here the gradient practically remains the same. So you remember this, increased pulse pressure is because of the low diastolic pressure because of decrease in SVR after the ectopic beat. So what ectopic beat is causing? Poor LV stroke volume, acute hemodynamic autoregulation, decrease in SVR, and low aortic diastolic pressure. And coming to your favorite spotter, what is this now? So this is HOCL. So can you understand what are the differences between the previous trace and this trace? Can anybody explain? So again, there is a resting gradient between the LV and the aorta. Again, same thing has happened. The ectopic beat came, but what has happened post ectopic beat? So somebody is writing aortic pressure is increased. So aortic pressure is not increased. So you have to understand what is increasing here. The LV pressure is markedly being increased. The diastolic pressure is going down because of the natural phenomena. The diastolic pressure will go down. Because of this excessive increase in the LV pressure, the aortic systolic pressure is going down. There is increased stenosis that is causing the narrow pulse pressure. So till here, everything was same. The ectopic beat come, poor LV ejection, leading to the decrease in SVR. Decrease in SVR is causing the low diastolic pressure. In HOCM, the degree of obstruction depends on two things. One is the systemic vascular resistance, and the other thing is LV contractility. Here, both things are occurring simultaneously. The SVR is decreasing and the LV contractility is increasing because of Frank-Starling law, because of this compensatory pause and because of the increase in the diastolic time. This LV contractility is markedly increasing. So LV contractility is increasing, SVR is decreasing, this causing disproportionate increase in the dynamic LV outflow tract obstruction, leading to the markedly increased gradient. Systolic pressure is coming down. See, the systolic pressure has almost become half here. Pulse pressure is narrow despite being the diastolic pressure being low compared to here. So are you understanding? Am I clear or not? If I am clear, then I can go ahead, because these are two most important spotters. And if you answer these well in your exams, one or the other spotter will be shown to you in your exams. And if you answer all these points which I have taught you, then definitely you are going to impress your examiner. Anybody can tell this is the HOCM. Anybody, you can mug it up, this is HOCM, that is the pulse pressure is increasing, then it is a valvular aortic stenosis. The pulse pressure is decreasing, then it is a HOCM. Even that way I have remembered while I was passing my DM exam. But this is not the way while you explain in your DM exit. Okay. So the two mechanisms are decrease in SVR and increase in LV contractility. Both are contributing for the worsening of LV outflow tract obstruction, leading to exponential increase in the LV systolic pressure. Okay, very simple. What pressure is being recorded here? Okay, so it is LVEDP. Two more questions. At in what phase of the respiratory cycle we measure the LVEDP? It is okay. End expiration. It is end expiration. Suppose you have got these 1, 2, 3, 4, 5 values. Which value will you take? Okay, Siddharth has answered correctly. So you have to take the highest value. So if you are having got respiration you are measuring, then you have to take either at the white end expiration or you have to take the highest value. So identify this trace. So here markings are not given. So you have to identify which chambers are these, what are these traces. So first identify the trace, the yellow trace and the red trace. What is the yellow trace and what is the red trace? The yellow trace is LV, so red is aorta. So the yellow trace is LV, red is aorta. Why it is red and LV and aorta? So both are peaking between the two R waves. Okay, the aortic pressure wave in diastole is downsloping, and this is clearly upsloping. So upsloping in diastole is LV, downsloping in diastole is aorta. So these are the aortic and the aorta and the LV pressure trace. So what you can see is, what is the most conspicuous finding here is, I'm not asking the diagnosis. What is the most conspicuous finding here? In one word, what will you say? You are close, but the answer is not fully correct. Increased pulse pressure is one finding. Raised LV EDP is second finding. Low aortic diastolic pressure is third finding. So Shanti has given the correct answer. It is the equalization of the LV diastolic pressure. So if we draw a line from the peak of the R wave, so R wave will be crossing here. So it is a near equalization of the LV and diastolic pressure and the aortic diastolic pressure. So that is the most conspicuous finding of this trace. If you say this finding as your first explanation, you will get full marks. You don't have to say increased pulse pressure, raised LVDP. So this is the classical sign of severe aortic regurgitation. So the findings are wide aortic pulse pressure, raised LVDP, near equalization of the diastolic pressure of aorta and LV. So my second question is, what is AR index and what is its prognostic significance? So where the AR index is used? So AR volume per body square meter. It is a wild guess, but not correct. Okay, Shanti has again told post hour. Very good. Post hour or post BAV patient, we calculate the AR index. So what is AR index? This thing can be shown to you in spotters, and you have maybe asked to calculate the AR index. So AR index is nothing but how much the diastolic blood pressure is coming down. So it is the diastolic blood pressure minus the LVDP divided by the systolic blood pressure. So here the diastolic blood pressure is 40, 40 minus 20 divided by 120 into 100, 16.7. So the lower the diastolic pressure, the lesser will be the AR index. And the lesser the AR index means the severe the aortic regurgitation and poorer is the prognosis. So during the trials and the data, they have shown that if the AR index is less than 25, the patient has a poor prognosis and increased mortality risk. So post AVI, you can calculate your AR index and you can say whether this AR is worsening your prognosis or not. This is a frequently asked question in the spotters. Okay, interpret this trace and give your findings. First, you have to identify which trace, which chambers. red LA, blue LV. Okay, very good. Why red is LA or why it is a atrial pressure tracing? I am saying that this is aorta and there is a gradient between LV to LA or LV to aorta. Why it is not aorta? Why the red one is not aorta? So why it is not aorta? Because aorta will again peak along with LV. Here you can see two peaks, one peak here and second peak here. Second, the aorta will be down sloping in the diastole. It is again up sloping in the diastole. So it cannot be aorta. So this is the LA pressure trace and this is the LV pressure trace. So this part is systole and this part is diastole. So what is happening here? Can you tell? So one red one is LA, the blue one is aorta. What is happening? What is abnormal here? Pulsus bis variance, it cannot be pulsus bis variance. I have already told this is not a aorta. This is mitral stenosis. Okay. So there is clear-cut diastolic gradient between the left atrium and the left ventricle. So you have to say this is the patient of a mitral stenosis where the LA is having clear-cut diastolic gradient. There is a clear diastolic gradient between the LA and the LV pressures. The same patient underwent some procedure 3 days back. Now what has happened? Okay. So again, so this is the R wave. You draw a line from the peak of the R wave. Here the LV and diastolic pressures will be there. There is near disappearance of any of the diastolic gradient. Minimal gradient here is remaining. So this patient has undergone a successful BMV. So somebody is telling it is developed a mitral regurgitation. So if this patient has developed a mitral regurgitation, after the T wave, the V wave will appear. This V wave will increase. There has to be an increase in the V wave, but there is no increase in the V wave. So practically, this is a successful BMV without increase in the V wave. So what is the definition of successful BMV? You have to open the valve, you have to increase the valve area, you have to decrease the gradient without causing significant mitral regurgitation. So here the gradients have come down without causing significant mitral regurgitation. There is no increase in the V wave. So this is a case of post BMV patient without any increase in the mitral regurgitation. So these are extra points. If you say successful BMV without any increase in mitral regurgitation, then you will get extra points. So here both things can be seen. So one more important point is in mild mitral stenosis, A wave will be taller, but as the stenosis severity increases, the V wave continues to become taller and taller because atrial contraction will not be able to compensate the obstruction. So LA will become more and more stiff and the V wave will become taller. But V wave can also be taller because of the mitral regurgitation. Then how will you differentiate? So suppose this is a patient. So again, to emphasize, this patient has this will be a tall V wave This is the T wave. The positive wave which is occurring after the T wave will be the tall V wave. So this is a tall V wave. This is the Vy descent. There is a clear-cut diastolic gradient. So LA pressure is high, clear-cut diastolic gradient. Now the examiner is asking you whether this patient has a significant associated MR or not. You have to answer. Is there any associated MR in this patient, or this is the just case of severe MS? Can you tell just by looking at this trace? So diastolic gradient is there, LA pressure is high, this patient has significant mitral stenosis, but is there any associated significant MR, yes or no? So the answer is no. Why no? X descent has nothing to do with the MS or MR. Vy descent is slow. Very good. So I got an answer. So the Vy descent is very slow here. So from peak of this V wave till the end of the Y descent, almost half of the diastole, it is taking more than half of the diastole for the pressures to come down. So it is a slow Vy descent. But in case of the MR, the Vy descent will be very rapid. You can see here the same picture, tall V waves, but see the Vy descent is very rapid. Less than 1/3 of the diastole, the pressure has come down. So these two traces are different. Both have a diastolic gradient, but this patient has a significant mitral regurgitation, but that patient has a only mitral stenosis. So interpret the LV trace before and after the ASD device closure. Very good. So again, we draw a line from the R wave. So this is the LV EDP. And after the ASD device, the LV EDP has almost tripled. So LVDP has suddenly increased after putting the ASD device. So this is a restrictive LV physiology. So such patients can be elderly patient, hypertensive patient, diabetic cardiomyopathy associated CAD. So how can you preempt that which patient is going to behave in this manner? So if your baseline RA pressures are more than 8, or then you can think of, then this patient is a restrictive LV physiology, because so LV EDP is transmitted to LA and LA is transmitting to RA. So if RA pressure is more than 8, then it is indirectly saying that LVEDP is borderline high, and this LV is having a restrictive physiology. And if we close this ASD, then LV ADP can suddenly increase and patient may go into failure. So you have to be very cautious. If the RA pressure is high, especially in elderly patient, and you are closing ASD, then you have to think. You can balloon occlude and you can see whether the LV EDP is increasing or not. Or if you can, before releasing the device, wait for a few minutes and measure your LV EDP again. If it is rising, then you don't release your device. So identify this classical tracing. Aortic stenosis, coarctation of aorta. So Kumar has given the correct answer. It is a Carabello sign. So what is a Carabello sign? First, can you explain this trace? So LV and femoral artery pressures are being taken simultaneously. From one catheter, we are taking the femoral artery pressure, and from one catheter, we are taking the LV pressures. There is a clear-cut resting gradient between the LV and the femoral artery pressure, suggestive of the LV outflow tract obstruction. First part is clear. As soon as the catheter is pulled from LV into aorta, the femoral catheter is same there. As soon as the LV catheter is pulled from LV to aorta, there is increase in the femoral artery pressures. So why the femoral artery pressures are increasing? I have explained the trace to you. As the LV catheter is pulled into the aorta, the femoral artery pressures are increasing. So this is a Carabello sign. So what does Carabello sign states that in a patient of critical aortic stenosis, if the valve area is less than 0.7 centimeters square, and when we take especially a 7 French catheter or a higher catheter inside the LV, the catheter itself can decrease the area further and can decrease the aortic pressures. And when this catheter is withdrawn from LV into the aorta, there is an increase in the systolic pressure. This increase, if it's more than 5 mm of Hg, then it is called as positive Carabello sign. This sign is absent when the valve area is more than 0.7 centimeters square, or it may be absent if you take a smaller French catheter. If you are taking a 4 French catheter, then again it can be negative. So I hope I am clear. This is a simultaneous LV and femoral artery pressure recordings, clear-cut resting gradient suggestive of LV outflow tract obstruction. When the LV catheter is pulled into the aorta, there is increase in the femoral aortic pressure, suggestive of a positive Caravello sign, which is seen in critical aortic stenosis, where the catheter itself is increasing the obstruction of the LV outflow. And when this obstruction is removed, the femoral artery pressure increases. So what is the abnormality here? You have to explain the trace. Don't give the diagnosis just. So this is the pulmonary artery pressure. The pulmonary artery pressures are very low. These are only 9 by 4 millimeters of mercury. Once we are pulling the catheter, the pressures are going down even further. Here the pressures are in the range of 4 millimeters of mercury. And then pressures are suddenly going up. So you are correct. This is the case of severe pulmonary stenosis. But why the pressures are very low in the range of 9:4? One question. Second, why they are going further down here? So pressures are low here, very low, because this is the end hole catheter artifact. So pressure is, we are taking pressure from an end hole. The end hole is looking away from the blood flow. The blood is flowing from RV to pulmonary artery. Our catheter is into the pulmonary artery. The catheter is looking away from the direction of the pulmonary flow. So because of this end hole artifact, these pressures are very low. When we are pulling the catheter, once the catheter is coming into the obstructed part where the obstruction is, the pressures are going further down because of the Venturi phenomenon. And when the catheter is out into the RV, we can see the increased RV pressure. So what is simple Venturi phenomena is, we have a high pressure chamber which is RV. This is the pulmonary artery. This is the area of constriction, the pulmonary wall. Our catheter is placed here. So the flow is in this direction. Our catheter is looking away from the direction of the fluid flow. That's why there are very low pressures here. Once we come into the high constriction zone, because of this accelerated flow in this high constriction zone, the pressure further decreases here. So here was 9, becomes 4. And once we come back into the high pressure zone, here the pressure increases. So this is the grading of the severity of the obstruction of the pulmonary at the pulmonary wall level. So coming to the very interesting tracing, interpret this pressure trace. These pressure traces you daily see in your cath labs, and you must know how to interpret them. Which chamber? Okay, so can it be a left ventricular pressure trace? No. So how you have to look is, in the diastole, the pressures are coming down. It's a down sloping in diastole, peaking between the two R waves. Down sloping, single peak. So it has to be any of the great arteries. So it can be aorta or it can be PA. It cannot be LV, it cannot be RV, it cannot be LA, it cannot be RA. So first you have to say it is a great arterial pressure trace. Either can be a PA or can be aorta. Suppose I am saying this is aorta. So what is wrong in this pressure trace? This is the arterial pressure trace. What is wrong? Okay, somebody has given the correct answer. So somebody is trying to engage the left main coronary artery, and simultaneous pressure is being shown like this. So what you can see is absence of the dicrotic notch. No dicrotic notch and low systolic pressures. This is a damped pressure dampening. This is a damped pressure trace because of the partial obstruction at the level of the stenosed left main coronary artery. So once the catheter was pulled, the trace becomes normal. Here you can see the dicrotic notch, the pressures have gone up, and now this is a beautiful looking trace in the same patient. So how the trace changes? So once you are doing an angiogram and you see this kind of pressure trace, the systolic pressure even maybe more than 100 because the patient's baseline pressure may be 170, 180. So you may look a good pressure, systolic pressure 120, 110, 116, but if the dicrotic notch is absent, then you may check again before injecting contrast. So interpret this pressure tracing. So there are two pressure tracing. So somebody is saying it is ventricularization. So what is ventricularization? And why does it occur? You have heard this term very often in your cath lab postings. The catheter is ventricularized. What does it mean? Somebody is saying that catheter is in LV. Catheter crosses the aorta and enter in the LV, somebody is saying. So here you can clearly see the aortic pressure tracing. You can clearly see the dicrotic notch, systolic pressure is good, diastolic pressure is good. Suddenly the pressure waveform changes. So pressure waveform have become more broad, a dome shaped, looking like a ventricular trace with a low diastolic pressure. So these pressures have become more like a ventricle. Why does this occurring? Because the catheter has wedged into the coronary ostium. The diameter of the catheter is almost equal to the diameter of the coronary ostium. So the catheter is closely wedged into the coronary ostium and it is reflecting the LV pressures. It's not reflecting the true LV pressures. This is a damped LV pressure. So this is a combined trace between the damped pressure of the aorta and the transmitted pressures of the LV. So this is not a true LV pressures. In the true LV pressures, the diastolic pressure of the LV will go down further and the LV systolic pressures will be almost equivalent to the aortic systolic pressures. So this is not a true LV pressures. You have to remember this thing. Here the LV systolic pressures are less than the aortic pressures. And the diastolic pressures are higher than the true LV and diastolic pressures. So this is the damped trace because of the ventricularization. Ventricularization means the wedging of the catheter into the coronary ostium when the coronary diameter, ostial diameter is almost equal to the diameter of the catheter. And both are snugly fitting into each other, and here the flow into the coronary is obstructed and now the coronary is reflecting that, is transmitting the LV pressures. So again, to revise, somebody is trying to do the right coronary angiogram, and these 4 tracings were recorded by 4 different persons while doing a right coronary angiogram. Can you describe all these 4 traces? So what is happening in trace 1? It is similar to the previous 2 questions. Okay, Sarthak has told the first is ventricularization. Very good. It is again because of the wedging of the catheter. This is the LV systolic pressure is going down, the diastolic pressures are going down, and the catheter is wedged. What do you have to do? If the catheter is ventricularizing, you have to reposition your catheter. The right coronary artery, the simplest maneuver to remove the ventricularization is you anti-clockwise rotate your catheter. Do not pull your catheter abruptly. Just gradually anti-clockwise it once the pressure is normalized. So this is ventricularization because of the wedging of the catheter into the coronary artery, and somebody has repositioned the catheter and pressures will become fine. What is happening into trace 2? So why this pressure suddenly become to 0? Okay. So catheter is deeply engaged and maybe hitting the wall or gone into the plaque. So wedging is a different word. Wedging is used when it is snugly fitting into the ostium. Then it is wedging. So somebody is asked what is the difference between damping and ventricularization. I will go back to the previous slides again. So damping is decrease in the not absence of the normal waveforms. The dicrotic notch will be lost. Both the systolic and the diastolic pressure will decrease, but the waveform will be of the aorta only. This is damping. In the ventricularization, the pattern of the waveform changes. The waveform will look like a ventricular waveform. If the dampening is also associated with ventricularization, then the systolic pressure will decrease. If there is no dampening, then the LV systolic pressure will be equivalent to the aortic pressure. So here the catheter is hitting the wall or gone deep into the plaque, and now there is no flow into the catheter. So catheter cannot transmit any of the pressure waves, and there is a progressive dampening and the pressure becomes 0. Here you have to pull your catheter till you resume your pressures. What has happened in figure 3? So the person is trying to engage the right coronary artery, clockwise, 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 he rotated, and the catheter is dropped into the LV. And now you see the difference between 1 and 3. Here the systolic pressures are down. Here the systolic pressures are normal. Here the diastolic pressures are very low. Here the diastolic pressures are in between. So ventriculations are the reflected LV pressures. These are not the true LV pressures. So these are different from the true LV pressure. Here the catheter has gone into the LV. Here it is transmitting the reflected LV pressure because of the catheter snugly fitting into the coronary ostium. So this is ventricularization. This is obstruction of the catheter while it is deeply engaged into the plaque or hitting the wall. It has gone into the LV. And what is this? This is, you have done the angiogram and now suddenly you see your catheter pressures are somewhat not looking good. So this is because you are using a fluid filled pressure system. This is dampening because of the contrast. Now your whole system is filled with contrast. Here the good pressures are because initially it may be filled with saline or blood, which are relatively less viscous. Now your whole system, whole catheter is filled with contrast, and contrast is more viscous and it is not transmitting the true pressures. So if your pressures are looking like this, first you remove all the contrast and then you look at your pressures. Here nothing abnormal has occurred. It is just dampening because of the contrast. So interpret this pressure tracing and suggest the corrective action. So one of the simplest spotter of this class. Interpret, don't give the diagnosis. So first look at the ECG. What is the rhythm?
Dr. Ankit, after this, we'll stop.
Yes, sir.
If you are okay with it.
Yes, sir. Yes.
Yeah. But I mean, very beautiful trace.
So this patient has a atrial fibrillation. Almost all the waveforms are below zero. The mean pressure is negative, which is not compatible with life. So this is a zeroing error. Suppose this patient is of ICU and you are measuring with a monitor and you have a transducer. What will be the position of the transducer in this patient? What will you do to correct it? Make it higher or make it lower? So transducer is already above the chest level and you have to make the transducer down. So you must have seen in the ICUs that sometimes the transducer drops bedside and the pressure suddenly increases. So if the transducer is lower, the pressure will be falsely high. If the transducer is higher up, the pressures will be falsely low. So in this patient, you have to make the transducer lower. The transducer is falsely high. So how will you describe this trace? Again, this is a simultaneous ECG in pressure recording. Multiple waveforms in one cardiac cycle, suggestive of venous waveforms. AF in the ECG. Mean pressure is negative, leading to because of the improper zeroing. The transducer is above the chest level. So these 5 points you have to describe in your this tracing. So once you describe all these 5 points and correct, you say what has to be done, then your answer will be complete. So with the permission of respected Vimal sir, we can stop here and we can continue
Because
later in next class.
not by permission, Dr. Ankit. You can continue throughout the night. I don't mind that. But thing is ki that 7:45 is generally the last,
Yes, sir.
kind of
Sorry, sir,
this
because
thing.
of the initial glitches.
No, no, it's okay. It's perfectly fine. I mean, it's perfectly okay, actually. Uh, it's perfectly fine. I mean, that no, don't say that, please. So, Dr. Ankit, as usual, I mean, for students, those, especially for those who are getting very, very impatient with 5 minute delay. So, especially for them, and read more actually, focus more on studies rather than here and there these glitches. Focus more on, you should be very focused. Do not comment on this thing when will start and all that. So obviously it will start, then we are sitting here. I mean, I'm not sitting here just for fun's sake, that's for sure. Nevertheless, so read and try to answer correctly and give the, as sir said, in one of this thing comment, that I don't want diagnosis, I want to know the findings, because findings are the key. I mean, you will get thousands and thousands. Each patient trace will be different, and for each patient also, for different patient, for each patient also different timing, you will have different traces. So if your search in the first slide, that upstroke, and I like that fundamental actually extraordinarily. So you have to follow those things. So Dr. Ankit, you have lots of thank yous, and I mean, these thank yous will only create more problem for you, in the sense that you will have to join us not in near future but in future. Thank you so much once again, Dr. Ankit. And dear students, thank you for joining us in large numbers, and do study, and best of luck. Okay. Thank you, Dr. Ankit.
Most welcome. Thank you, sir.
And Sumit sir, can we leave, sir?
Thank you, sir. Thank you, everyone, for
Sir,
joining the
thank
session.
you. Thank you for giving us permission. Thanks once again.
Thank you,
Thank
sir.
you.